So your hosts for today's webinar from the Impact Research Group are myself, Carrie Jackson. I'm Director of the Impact Research Group and Associate Professor for Practice Transformation, and as of 2 weeks ago, Director for the Health and Social Care Partnership at UEA. And I'm joined from the Impact team by Professor Sally Hardy, who is Dean of the School of Health Sciences in the Faculty of Medicine and Health Sciences. And our colleagues, Professor Kim Manley and Professor Jonathan Webster, have helped in the arrangement of today. Next slide, please. So the focus of our session today is leading sustainable change at scale and gaining international insights from working from practice to influence policy. Next slide. And I'm absolutely delighted to welcome Professor Andreas Büscher, who is Professor of Nursing Science at Osnabrück University of Applied Sciences, where he's held that position since 2011, and is leader of the German Network for Quality Development in Nursing, and that abbreviated stands for the Dnqp. And he has further research interests in home and community-based care. And Andreas is going to be presenting his slide deck first and talking about experiences of running that particular network. And then he'll be followed by Professor Wendy Cross, who is Deputy Vice-Chancellor at the Academic at Federation University Australia. Wendy's held senior appointments within Australia and has a number of honorary professorial appointments. She is past President of the Australian College of Mental Health Nurses, Chair of the Council of Deans of Nursing Midwifery for Australia and New Zealand, and Fellow of the Australian College of Nursing and a Fellow of the Australian College of Mental Health Nurses. So we're absolutely delighted to be able to welcome both our esteemed guests, and thank you both very much for giving up your time this morning. For our participants who've just joined, Wendy is in Australia and therefore is 10 hours ahead in the evening, and Andreas in Germany is 1 hour ahead of us here in the UK. So thank you very much. I'm going to ask for the next slide, please, Emily, and hand you over to Andreas. Thank you, Andreas.
Yeah, thank you very much, Carrie, for this very kind introduction, and good morning, everybody from Germany. I can say good morning, with 1 hour ahead of you in England. Well, I'm happy to be invited and to have a chance to introduce you to the work of the German Network for Quality Development in Nursing, a work that somehow, is an example for sustainable change in nursing in Germany. We celebrate our 30th anniversary this year, so this is some kind of sustainability, and I hope I'll be able within the next 20 to 25 minutes to give you an impression of what we do. You see in the on the slide, what we try to do is to implement evidence-based standards in nursing care across all settings in Germany. Next slide. The background of our work is actually a WHO Europe initiative on quality of nursing care. Within the program of Health for All to the year 2000, there was a bit on quality of care, and there was also a bit of quality of nursing care. And a group was established in this time in 1992. It was called EuroQuen, the European Quality Assurance Network, and it was taken over from by the Oxford Institute of Nursing, the Royal College of Nursing Institute. So actually there's a UK history of this. And this group in 1992 had the aim of establishing national networks in all the participating countries. As far as I know, there was only the German approach successful until today. I mean, there are other approaches in other countries to quality development in nursing, but from EuroQuen to now the 30 years, there's, as far as I know, only a German history. So the Dnqp was founded also in 1992 by my predecessor, Doris Schiemann, here at our University of Applied Sciences in Osnabrück. And the work of the Dnqp actually started on a very low scale with sharing examples of good practice. But it got a push actually in 1999 when the German health ministers of the 16 federal states of Germany, they called for the development of standards in nursing and guidelines in medicine on 10 priority areas of health care. And this actually was the start of official funding and supporting the work of medical organizations, nursing organizations, to develop something that was in a very early state of guideline development and standard development. And from 1999 to 2009, the German Ministry of Health funded the work of the Dnqp, the work for the development of 7 expert standards. The next slide, please. So what is the Dnqp actually doing? Our main work is related to the development, the consensus building, the implementation, and the updating of evidence-based expert standards. And we put emphasis on all the 4 parts of it, because all the 4, they have a methodological approach that has been developed over the years, and that's has proven to be quite successful. Besides that, we try to investigate methods and instruments for quality development and measurement, but the main focus of our work actually is, as I said, the development, consensus building, implementation, and updating. Next slide, please. To give you an impression what the Dnqp actually is, this slide presents the structure of the network. And actually, it is a network. We are not an institute, we are not a company, we are a network. And because we think that networking is an important part of quality development. You see on top there is a Dnqp steering group consisting of representatives from different nursing organizations in Germany, from the nursing management, from the nursing education part, from nursing science, people representing the big university hospitals, people representing nursing homes and home care services. And this steering group actually decides about the standards that the Dnqp is going to develop. So they make the big decisions. On the right hand, you see groups of experts for developing expert standards. So part of our network is that we actually convene groups, and we try in the German-speaking world always to find the best expertise for the issues and the themes, the topics that the expert standards address. I will give you an overview on the next on one of the next slides. And for each subject that we develop an expert standard on, we have a different group of experts from the nursing science, but also from the nursing practice world. Also on the right, we have partner institutions for pilot implementations. Unlike other approaches to guideline development, in our approach, the pilot implementation is a part of it. So we do not publish the final product without having done a pilot implementation in 25 to 30 institutions, and they are also part of our network. We cooperate with the German Nursing Council because we think there has to be some legitimation for what we are doing in the nursing world. Meanwhile, I think we are quite well respected and acknowledged for what we do, but for us it is important to have a link to the organized nursing profession in Germany. On the left, you see the nursing community, because we actually are very interested in working with all people who are interested in spending time and engagement on quality development. So there's nobody is excluded, so we try to include as many people as possible. And on the left, we also see so-called reference institutions for the sustained expert standard utilization. So we know that for practice development, it is quite more important if a person interested in one hospital talks to a person in another hospital to know how it's going to work and what are the barriers and what are the promoting factors for working with the standards to improve the quality of care. In the middle, you see the office here in Osnabrück, here at our university. We have 2 people in the office with 1.75 full-time equivalents, and we have a scientific team of 4 people, and we have the scientific leadership, which is myself. So it's a very small team to ensure this work. So what are expert standards now? Please, the next slide. It's not so easy to find an appropriate English translation, but I think this one is quite quite close to the original German definition. We say that expert standards are a professionally determined level of professional performance that matches the needs of the population served and applies criteria for its evaluation. So this actually means that the profession itself, the nursing profession in Germany and also in the other German-speaking countries, Switzerland and Austria, they decide on what is their level of professional performance based on evidence and based on practice experience. So that is the important thing, and we ensure as Dnqp this development process. The expert standards, they give direction to complex professional interventions. They provide margins and alternatives for professional action, which always means that we need nurses who make their decisions based on standards, based on evidence, based on experience. They are suited for nursing care problems that require considerable attention and that are characterized by a highly interactive nature. So some call this complex interventions. I think this is very close to what we try to address with the standards. The next slide, please. And here you see the expert standards that have been developed from 1999 to, oh sorry, there's a mistake on the slide, to 2021 it should be. And you see those are areas of nursing practice that occur in all settings, no matter if it's a hospital, a nursing home, or a home care service. The first one was on the prevention of pressure ulcers. There's one on discharge management. There's one on pain management, one on fall prevention, promotion of urinary continence, care of people with chronic wounds, nutrition management, forming relationships with people with dementia, the promotion of oral health, which we developed together with the dentist organizations in Germany. We are working on one on skin care. There has been one on the maintenance and promotion of mobility in long-term care. And we once worked with the midwives in Germany for a midwifery standard on supporting normal birth. On the right hand, you see the year of the development, and you see the first update and the second update. Like all evidence-based instruments, these standards need continuous updating so that they are that they reflect the current best evidence. And we also include in the updating process a lot of practice experience that we get from the implementation project, that we get from the practice sites when working with the standards. Because I don't know what your experience is in the UK, our in Germany is that not all problems that occur in practice are published in peer-reviewed journals. Sometimes they just occur in discussions that people have within networking structures. And so we try to include this in the updating process, and we always learn quite a lot in these updating processes. Just to give you an example, for the first update for the fall prevention standard, we got anecdotal evidence that the publication of the standard first led in some nursing homes to increased use of restraints, because nurses were afraid that people fall, and they thought that people should not fall. And one way to prevent them from falling was to restrain them in their bed, which was not stated in the standard, but it was just a mistaken perception of it. And in the updating, we clearly stated that this is not a measure of fall prevention. So there's a chance in the update not only to include the newest evidence, but also a lot of practice experience. The next standard, please. The next slide. Next standard. So this is the form and structure of an expert standard. So they all look the same. The standard itself is just a one-page document. It goes along with a large commentary on the different criteria, and with all the literature that has been identified and analyzed to develop the standard. You see here we have the structure in the columns. We have the structure, process, and outcome criteria, and the rest of the standard is built up according to the steps of the nursing process, because the nursing process is the baseline for professional nursing care in Germany, and I guess in other countries too. So all the standards have the same structure. They start with the assessment of the phenomenon of the standard. They go on with the planning, coordinating, and negotiating with the client who receives nursing care about the type and intensity of care. Then there is the performing and doing of something. We always have a separate part of separate criteria on informing, advising, and counseling, because we learned that at least in Germany, nurses are need some support in strengthening the informing, advising, and counseling part of their work. So that's why we always have a separate part, a separate criteria on this. And finally, there is the evaluation, and this is the same for all the different standards. There's a scope and purpose statement that that summarizes what the standard is all about, what is the main aim of it, and with this structure, all the standards that you have seen on the slide before, they are published in this way. The next slide, please. So what is the methodological approach? We have a regularly updated method paper, we call it. Unfortunately, it's in German only. And the core principles are that we convene an independent expert panel, as I said. So we make a public call and we get a lot of applications from people from all over Germany, Switzerland, and Austria who want to be part of this experts group. They have to prove that they have some expertise, either academically or practically, and the groups consist of 10 to 15 members. In all groups, we have representatives from client groups, and sometimes we have people who are not nurses but who have a strong relation to the subject. For example, in the nutrition management standard, we had a nutritionist. In the mobility standard, there was a physiotherapist, and so on. So it's usually the expert panel consists of nurses only, but we have some additional people to complete the panel. The job of the panel is to develop the standard based on analysis and appraisal of the existing research. The group has a leadership, which is not me or us, which is a person who has a strong expertise, and this person is also responsible for conducting a literature search and analysis. This search and analysis is paid by us, and this is the basis for the development of the standard. When the group has developed the draft of a standard, we conduct a huge conference with 500 to 1,000 people. So nurses from all over can attend the conference, and the intention of the conference is not to listen to presentations. The intention of the conference and the aim is to discuss the standard. So everybody gets the standard, the commentary, the literature 6 weeks in advance to the conference, is well prepared, and this is a real dialogue, a real discourse about the right way of how nurses should address the different subjects that the standards are going to address, the quality problems in nursing care in all settings. It's a very lively discussion, and it always leads to changes, amendments in the draft of the standard. And all the results from the conference, they will be taken up by the expert panel, and then the final draft will be developed based on the results of the conference. And with this final draft, we start the pilot implementation. Again, we do a public call in the media, and we get a lot of applications from hospitals, nursing homes, home care services, and meanwhile we also get from different other settings. And then we do a so-called pilot implementation, and we do, at the end of the implementation, we do an audit to see the practicability, and we evaluate the goal attainment. So to which degree have the participating institutions attained the goals of the standard, and what can they do to improve their practice? The next slide, please. You see here we call it a phase model for implementation. it actually is very close to the, or it contains a lot of aspects of the Parish framework, which some of you might be familiar with. There is the preparation on the left-hand side, and the preparation is important in the institutions to, well, to build a group that is taking on the work in the institution, and to have a person which, well, in the Parish framework is called the facilitator. And this person, the responsibility of this person is really to keep things going and to move things forward within the institution. The four phases, as you can see, they overlap. They can be distinguished, but there's a strong overlap. There's a training and education phase. Within this phase, there's the training on the criterion levels of the expert standard. And this is, well, it depends on the history of the institution. Have they addressed the problem beforehand? Is there a higher demand on training and education? So this is a decision that the institutions have to make. Then there is the adaptation, which is quite an important thing, because the standard is, well, it's intended to address the subject for all settings. But of course, the work on intensive care units is different than in home care. So there need to be adaptations made. For example, which kind of assessment actually is used, and so how to work interdisciplinary. All these things need to be adapted, and this is an important work in the implementation process. Then there is the actual introduction, where nurses should be allowed and should have a chance to test and practice the standard and the adapted version of it for the institution. And finally, there is an audit. We have developed a standardized audit instrument to evaluate the degree of goal attainment for the different criteria of the standard. This process takes about 6 to 9 minutes, and all the institutions that take part in this implementation, they come together here in Osnabrück for 3 times during this process, basically to network. So some have the expectation that we tell them how to do it, but we tell them no, they have to tell themselves how to do it, and to really network, to exchange how they managed and what problems they faced and how they solved the problems. And this really puts forward the dialogue and the exchange and the development of a good practice. And finally, the results of this implementation process, they are part of the final publication of the standard, so that others who have not been part of this pilot implementation have a chance to read about the results and can use these results for their own implementation. The next slide, please. So if we summarize a little bit what the core functions of expert standards are in the German-speaking nursing world, they help for the definition of professional functions and accountabilities. We see this in several respects. Then sometimes when people try to define what nurses actually do, they very often look in the expert standards and they see, well, this is not all that nurses do, but it is a large part of what nurses do, and it actually is, it has been developed on a sound methodological base. The standards initiate and they promote innovation in all healthcare and long-term care facilities that actually use them. So we get a lot of feedback how the work with the standards actually, well, led to innovation in these facilities. For nurses, they promote an evidence-based professional practice and identity. They're an example, not the only one, but they are a very important example of base the actual practice on current best evidence and on practice experience. And they are a basis for constructive dialogue on quality of care with other professions. We are often criticized for the monodisciplinary development process, but we always say, well, the agreement and the negotiation within the profession is a prerequisite for then you going into the dialogue with other professions. I think this works quite better than all these professional fights that go on in other settings. So we have quite good experiences with that. The next one, please. So what impact have the expert standards made? We have a high demand from hospitals, nursing homes, and home care services. And just to give you an impression, the work of the Dnqp is not funded by anybody. So I told you in the beginning that during the first 10 years, the German Ministry of Health has given some money for the development of standards, but all the updating, all the new standards that have been developed after 2009, there has been no public funding for it. We sell the standards as books. So the one page you can see freely on the internet, but the whole thing, the standard with the commentary, with the literature, they are published in books of about 150 to 300 pages. And the work is actually funding itself, because the people from different settings, they order the standards, and this allows us to have this totally independent work of quality development. And the demand is really, really high. Every time we publish a new standard, there are 10,000 and more, 15,000 orders from the nursing world in the German-speaking countries. We know that within the German nursing journals, the professional journals, there have been several hundred publications. We once stopped counting them on the standards and the use of the standards, problems with the standards, chances by the standards, and all these publications have been done by people working in practice using the standards, so they have a real impact. We know that the standards are used in lawsuits every time when somebody is making a claim, for example, because of a pressure sore, because of a fall. When the court has to decide, well, was the best practice used, was evidence-based practice used, they look into the standards on to make their decisions. The implementation model is one way of supporting the theory-practice transfer, which still is an issue in the German-speaking nursing world. It is a statement on professional responsibility that is actually quite acknowledged by other professions. We have every now and then we have some discussions with the physicians' organizations in Germany, and they respect and acknowledge the work that we are doing, but they also, for example, on the standard of pain management, they have some concerns that nurses have crossed their borders. So there's a real dialogue, and there is some impact on this, on professional boundaries and professional scopes of practice. From our point of view, we always say that the health and long-term care facilities, the institutions, they should use the standards for their internal quality management. They should use this for internal processes, for promoting their own way of quality development. And I think we have found a way to integrating the user perspective via participation in the development and updating process, and also by stressing that in nursing practice, the negotiation with the care recipients and the interactive nature of almost all things that nurses are doing are quite important, and we stress this, and we give some advice and some support of how this is best done. Well, this is just in a nutshell the work that we are trying to do, that we have done for the last 30 years. And I don't know if we do it for the next 30 years. I'm not doing it for the next 30 years, but I hope to do it for some more years in the future. And I thank for your attention, and I'm happy to receive questions, comments, or whatever. Thank you very much.
Andreas, thank you very much for sharing your work with us. That's really fantastic. We'll take some questions at the end, if that's okay with you. And I know that there's a lot of activity in the chat box. So I'm going to hand over now to Professor Wendy Cross, and then I'll come back on camera after Wendy's presentation. Thank you, Wendy. Thank you, Andreas.
Thank you, Kerry, and thank you, Andreas. It's such an interesting well, it was so important work that we have standards, and the way in which your group has brought them together and published them has been wonderful. Thank you, everybody, for joining us tonight. It's tonight in Australia, so good morning to you all in the UK and wherever you might be joining this from. I'm going to be talking to you about a group of work or a piece of work that I've been doing over a number of years with a group of very, very senior nurse consultants. And about the use of facilitation and how we've gone over a number of years in terms of the way in which I've utilised some of the theory in practice development to facilitate their growth and development. But not only that, but what happened when COVID hit. So I wanted to, it's kind of like a geared change. We start off with some theory, what we did in the first 4 years, and then what we've done over the last 2 years in COVID. And I can't begin to imagine what might occur in 2022. I can only hope that where we've been will provide the roadmap for where we'll go. So, new slide. Thank you. So some background about the work. So I've been facilitating this group for 6 years, and as I said, in the last 2 years in the COVID context, and which has been quite difficult, as you all would be understanding of that. The group of nurses that I've been working with work for a very major metropolitan health service. It's a tertiary referral centre, and it encompasses multiple settings, both bed-based and ambulatory. And the group are palliative care nurse consultants. And as you can imagine, a nurse consultant has extensive nursing experience. They're senior clinicians. They work within a team, not allied health disciplines to generally speaking in their team. They do have medical specialists and registrars in their team, but the allied health professionals and the other professionals that they work with are in the wards or in the ambulatory care settings. So this particular health services is an absolutely, it's a juggernaut of a service, and they provide all the consultancy for all end-of-life care across the whole of the service, whether it's inpatient, acute settings, ambulatory settings, rehabilitation settings, oncology settings, and so forth. So it's a very wide ranging context for this group of nurses. So next slide. What I'm going to do now, though, is talk to you about some theoretical underpinnings, and this might be a bit boring for some of you, but I know that we've already talked about today in this particular webinar about the difficulty it is about describing and understanding what practice development is. And, you know, it has been quite difficult over a period of time to define it, but I love this particular definition from Manley, McCormack and Wilson. It's quite old, 2008, but it just sums it up so well and includes the main dimensions that I'm going to focus on this evening, and that is a continuous process of developing person-centered cultures. It's enabled by facilitation, authenticity, engaging with people, blending the personal qualities and creative imagination, bringing the practice skills and practice wisdom together. That's the important components. Learning occurs during all of the processes, and it brings about the transformations, both of the individual and of the team. And it's so important that all of those things come together. And it's sustained organisationally by embedding those things in the corporate strategy. And of course, in Australia, and I'll talk about that, there was a time when practice development was absolutely embedded in corporate strategy, in some jurisdictions more than others. And it's starting to re-emerge. And I think that that's really important, because what we've shown in recent times is that we need to have some grounding in person-centeredness, person-centered processes, being authentic, able to be facilitative and help people to learn. So these are the basic theoretical underpinnings. Now, if you take the key terms here, person-centeredness, authentic engagement, learning and facilitation, then I'm going to just bring those to the fore, because then I'm going to apply them in the way in which I worked with this group of very senior clinicians. Next slide. So if we take person-centeredness, it's about how you relate to other people, understanding their context, understanding how they relate to you, that they are social in the way in which they react. We have to know that it's inherently embedded in understanding them, respecting them and trusting them, and for them to trust us. It's existential, about being. And if you want to take Van Manen to the next level, it's about the lived, the life existentials and so forth, people, place, context and all of those sorts of things. Being with yourself, understanding you. And that's really absolutely important, about understanding self. And these ways of beings means that we exist in relation to one another. So when I talk about the relationship in the group that I've been facilitating for 6 years now, they talk about their relationships with each other. They talk about their relationships with other people within the group. They are socialised in the workplace. They're socialised in their own environments, and we talk about what they do in terms of relaxation and various other things. They are developing their own sense of self through this, but recognising how they exist in relationship to others and how they respect each other and trust each other. And this team do trust and respect each other immensely. And that's really, really a fundamental component of being person-centered. So the next slide. Clearly, to undertake the work that we do as nurses requires being authentic, as an authentic being. That requires self-awareness. It's absolutely essential for enabling others, whether that's as a clinician in the workplace or whether we're working in practice development procedures or facilitating other things. What we want to do is empower people. We want to give them the power to make their own decisions, to understand those decisions, that they are intentional, not random. It's not serendipitous. They're intentionally using themselves to understand. And of course, if these sorts of things of understanding self is absolutely critical for me as a facilitator and as a critical companion. So I'm not going to focus too much today on critical companionship, because I think that's a similar but different relationship, because it's more of a one-on-one. This is about facilitating group interactions, group thinking, group agreement and so forth. So the two main attributes of that is about knowing our own beliefs and values and being authentic, living, so not just espousing them, but living them, being true to you, being true to yourself, and really saying how it is and how it's not. That can sometimes get people's backs up, as we might say in Australia, but it is about the way it is. You have to be honest. It's consistency, it's integrity, and it's in transparency. I'm a pretty transparent person, and most people know when I'm cranky or when I'm not or when I'm happy, and that's the way it is. And I don't shy away from that. That's the way I am. Practice developers, though, we embody a range of all of those attributes that I've just been talking about, and we cluster those around the idea about supporting people, mentoring people, having an empathic understanding, putting yourself in their place. What would you do if you were them? How would you do that? How would you be that person? Valuing others, the humanistic approach to everything. All humans have value regardless. So how do you put all of that in place? And then how do you create a transformational process that leads others to their own conclusions, empowers them, and enlightens them to the next stage. And, you know, whatever you do in terms of practice development, how authentic you are, however you want to engage with the principles of person-centeredness, whatever, you have to facilitate that in some way. So all of practice development relates to facilitation of some sort, and it could be a range of different ways of doing things. Next slide. So I'm going to talk about facilitation now, because this is really about how I facilitated this group of people over a number of years in terms of them understanding their own role, their understanding of their own position in the organisation, their relationships with others, and so forth. So this is a little bit theoretical, much more than perhaps that I've embarked upon right now. But, you know, I want to take you to Heron. It's an old model, but, you know, hey, it's a goodie. It reflects the multiple dimensions of emotion, resistance, meaning. When you think about working with people, people do bring their emotions out. They are resistant sometimes to even talking about certain things, or change, resistance to even saying something bad about something. So we have to work with all of those things. And how do we understand what it means? What does this mean for you? How does this mean for the team? What will you do with the meaning for the organisation? How will you respond to all of those things? And so it's about asking the questions, facilitating all of those dimensions, because there's a task at hand. There's always a task at hand. There's an issue that needs to be resolved or changed or whatever. Let's just go with that. We act in different ways at different times, depending on what the group says, what the individual says, what time it is, the stage of their development. And I can say at the beginning, we spent quite a few months getting to know one another. They didn't know me very well, but I'd been referred to them, and they took me on sight unseen. And so we developed this very, very strong bond over, it took months. And of course, people come in and out of the group depending on their schedules and so forth, but it does take time. So we need to not think that this occurs, you know, in a flash. We'd like to think so, but it doesn't. Now, the facilitator can be directive or non-directive depending on the circumstances. But of course, the issue is for the facilitator is that they need to determine what that means in terms of, should I be directive now or not? It's purposeful. It's not just about a chat, having a lovely time with an hour, spending an hour with people. None of us got time to waste. And so it's about being purposeful in that interaction, understanding what people are saying, working through it, drilling down onto what people are saying, challenging what they're saying. So Heron talks about the categories of that challenge or that interaction as facilitation. He calls them prescriptive, informative, confrontative, cathartic, catalytic, and supportive. And so all of those things are utilised in some way or other in terms of the facilitation process. He then went on to basically divide them in half, calling them authoritative or facilitative. Next slide. And here they are. And look, I'm not going to go into this slide in a lot of details because I'm going to refer to it again at the end. But, you know, do we tell people what to do? Do we give them information? Do we challenge them? How do we do that in a supportive and non-threatening way? Do we allow emotions to develop? Do we spur them on? Are we the catalyst for something new? And how do we just generally support and enable to go through to the next stage? And I will come back to this slide. I don't want to spend a lot of time on it because I think it's more important at the end. So next slide, please. And lastly, of course, is reflection. Now, I guess the thing about facilitation and facilitating action groups is about encouraging people to reflect upon themselves. So, and John's talks about the window in which we view ourselves, our context, our lived experience, which is unique in all sorts of ways. And it enables us to understand ourselves, our work, and all of the things that goes with that. I know it's an old quotation, and forgive me for that, but sometimes there's nothing better that comes out about this window to you and what you think and feel and do and understand. And not only that, what you will plan to change next, and you know, and in the next iteration. So Sean then goes on to really split it up in terms of reflection about the here and now, reflection about what happened and evaluating that, and reflection about what you will do next. You can't just, you know, ruminate. It's not about rumination. It's about saying, what happened? I was conscious about this. What is my conscious understanding of this? How will I utilize that? What do I understand about that? What will I learn from it? And my learnings will guide my actions into the future. So that's the next component for understanding reflections. And that's how we talk all of the time in our facilitation practices as we move through the group work. Next slide. So I want to then move forward in terms of reflection, because reflective practice is not just being thoughtful about things. It's really understanding and learning from it. And it's about the action. It's about deliberation about the best options or choices and how we reconstruct it and change for the future. Mesereau, also a very old, and I have gone back to the fundamentals, the absolutely seminal work in all of this, because I don't believe at this point in my very aged career that I have found anything better. So Mesereau identified 6 levels of reflexivity or reflectivity, and that is being aware of yourself, being aware of others, how you relate to those people, understanding your own feelings. You know, sometimes I say, what's pressing your button? How do you, are you angry? Are you sad? Are you emotional about this? How does this affect you? What is your reaction to decisions you've made? Has that decision been the one that you could have made at a different time or in a different place? What would you do differently in the future? Understanding your values. What assumptions are you making about situations, people, all the sorts of things that you might make assumptions about? And awareness of the concepts that underpin your decisions and the critical analysis of those. So the concepts of learning, the concepts of organisational redesign, the concepts of understanding clinical decisions. And I think if you go back to Andreas's points that he presented earlier, it's about the concepts of evidence, the concepts about why we do the things we do, and critically analysing those and putting them into place as we move forward. And then understanding ourselves in the context, in our own context, and how that context changed. And, you know, in this presentation, I'm going to talk about the context changing from regular facilitation to the facilitation in COVID. How did that change? Understanding of self in that context was really, really important, and altering our assumptions based on that new knowledge. And these are very, very important components. So I wanted to bring all of these theoretical underpinnings, and I know I probably bored you silly, but you know, at the end of the day, these are the things that drive what I do and my work with people. And this is one example of that. So next slide. So let's talk about what we did and how we did it. So in the first 4 years of this 6-year process, we worked together monthly meetings face to face, And I went to the health service. Obviously, they couldn't come to me, and that was fair enough. And so I went there and we had a cup of tea and we talked and we did all of the things that I would normally do in that situation. We naturally agreed on our ways of working. We reiterated those. As you would understand, teams come and go, people move in and move out. As new members joined, we just reiterated the ways of working. The basic premise was that it was a safe and open space for sharing, problem solving and planning. I invited members to share an issue. We explored them using Mazarow's framework about reflecting on self, reflecting on assumptions, emotions, and all of those sorts of things. So we went through, and some people weren't just reflecting on their emotions at the time, but they were reliving those emotions. So we were then going through the notions of dealing with catharsis and all of those other activities. So we would talk about all of those things in it. These sessions lasted for 1 hour, and at the 5-minute, towards the end of 5 minutes, I would then start to say, well, we need to wind this up, and I would ask them to identify a word or phrase that reflected their learning within that session, and that they would then say what would be their actions, taking those actions forward, and what they were planning to do. When we met the next time, I would review the outcomes of their actions. So I'd say, well, you said X, that you were going to do this and that and the other. How did that go? What did you learn from it? Did you try it? And so on and so forth. And we would then have that conversation, and everyone would join in, and there would be a lot of opportunities for conversation and suggestions, support, and the group support was developing more and more. Interestingly enough, I should point this out, that the manager of this group of very, very experienced consultants joined the group. We asked at the very beginning whether that's what they wanted, because often people don't want their manager to be part of the group. The manager is part of the group and has been a very, very supportive member of the group. There's been no issues with that regard. While she's the manager of the group, she's also a very active team member. And to date, after this is the 6th year, she continues to be part of the group. But we needed to obviously have that conversation early, and they agreed that she should be part of it, and has been, and it's been great. Interestingly enough, if we talk about all the conversations that we had over those 4 years, they generally themed around self-efficacy. How do I work? Am I good enough? I'm just going to this new place. How will I cope? Blah, blah. And then how do they relate to each other? Not so much in the team, but their interrelationships or the interpersonal relationships with other members within the ward structures and other members in the broader palliative care team, in particular the medical staff, their registrars, and the overall manager of the palliative care structure within that health service. And so ultimately we had a number of conversations around that and how they needed to work through what needed to occur for them to receive the things that they needed. It was quite solution focused. We talked about how do they want to hear your story, and sometimes it's not about the story, it's about the data. And so we talked about data and how we got it and what it means and how you would frame the data to your best interest and so on and so forth. The last obviously category, big major theme, was systems. And of course, when you're living and working in a major health service, as all of you are, the systems can actually do your head in. And they do create all sorts of problems. navigation, understanding decision making at the highest levels, the implications for all of those decisions as you work on the ground, and what the systems mean. So generally we had a lot of conversations of all of these things. They all went away each time, and we proceeded. Next slide. So here comes COVID-19. Next slide. Just a little bit of background about Australia, because I mean, obviously you're living through it right now, and as we all are in different ways in the Omicron variant and so forth. But you know, when I wrote this was like last week or something like that, the COVID pandemic had killed 2,367 Australians. I think it's killed a lot more since then. It's infected almost 1 million of us. We're very small. We're only 25 million people. Our economy's, you know, a bit shaky out of it all. Victoria is where I am. I'm my university, and I live in Victoria, which is one of the southern states in Australia. We were affected most in terms of the number of cases, the number of deaths, and the loss of income and work. But everyone has been affected in some respect in terms of restrictions, lockdown, social isolation, loss of income. And you understand all of that, as does everyone in the world these days. But I thought I would just see, what are we doing in terms of the research around COVID, in particular for nurses and in particular for mental health, because mental health's my background. So I did a quick PubMed search, got, you know, more than 200,000 hits. If I added nurses, there was another 4,500, and if I added mental health, more than 800. Interestingly, though, the articles coming forward were around stress, resilience, burnout, depression and anxiety, social isolation, and maladaptive coping strategies. And we, I haven't reported this in this particular setting, but we did a big global study on COVID, and we found that healthcare workers were generally okay, but there was still a proportion of them who rated their mental health as not great. And so we need, and in particular nurses, so we need to start to think about what this has done for our profession broadly. Anyway, I won't go into that, just another story. So next slide. So nurses, this is about nursing, nurses in the pandemic. We are affected in similar but different ways. We're all citizens, and that's what I think we need to remind ourselves, that nurses are citizens as well. We have family, we are community members, we are directly affected one way or other. I reckon every one of us knows somebody who has had COVID. My daughter just had it last week. So it's about how this affects us. Have we been unable to go to work because we're isolating? Those of us who can go to work are working on the front line. We might be providing care to people we know, particularly in smaller regional areas. You know, that's difficult. And there's unrelenting pressure, unrelenting workload. The hours are extended. People can't go on holidays in this country. We've said so. There's variable availability of resources. Early, the PPE stuff was very difficult to come by. And for this particular group, the increased need for end-of-life care, because people were dying of COVID. And this palliative care group had to come and support not just the people who were dying, not just their families, but the staff who were trying to deal with them. And that's where this takes its serious turn in the way in which we were talking to one another. Next slide. So my facilitation during the COVID pandemic, so we obviously couldn't do face-to-face meetings. We started meeting online when we could, because it was difficult for everyone to come into the room. And of course, if we couldn't do that, we just didn't do it. Sometimes instead of having a monthly meeting, we would miss a month and we would move on. Our ways of working and our processes remained the same. So we shared issues, we explored them, actions were set, and then we reviewed them at the next meeting. So the same sorts of things happened. Our discussion continued to stay around self-efficacy, interpersonal relationships and systems in the early days. So it was all still, how are we managing all of this? How are we coping? You know, am I able to do all of this and so forth? So that was fine. Nevertheless, there was greater emphasis in the conversations placed on the reaction to COVID restrictions in the workplace. So what this group found was the limited visiting hours, and in some instances there was no visitors. Visitors were banned. And of course, if you've got someone dying, because this is a palliative care service, how does that work? And how did you cope with that? What does that look like? And the need for increased end-of-life care, redeployment to other areas of the service. Nurses all of the time were taken from here and there to support areas of need within the service. And interestingly, over that period of time, in that first 12 months, the members were much more emotional in terms of their responses. And we worked through all of those emotional responses, whether they were just silence in the meeting, people just saying, look, I can't talk about this today. We allowed all of that. And once we went through the idea about catharsis, how do we do with the catalytic or creating a catalysis for the next stages, and we worked through all of those things. Often, though, we couldn't find a solution to whatever the issue was, and we really focused in that first 12 months was about coping with the situation, coping with what they had to do, getting through the next stages, coming to the next meeting with how well they did. And so the role of the facilitator was so much more supportive. And in fact, I would say in the last 2 years, I have been far more supportive than I have been in the past. Nevertheless, I'll get to that in the next couple of minutes. Next slide. So 2021 took a turn for the worse, really, in some respects. So the first half, in Australia, of course, we had the summer and we started thinking we were going okay. And then we started to have our monthly meetings, but they remained online, obviously. However, in July, we had the Delta variant, and it took a hold, not just in our state, but across the country. And there were increased restrictions. And interesting in this, obviously, with the Delta variant, so many more staff are affected, as we've now also found with Omicron, and then in the first wave. So meetings became more sporadic, and in that second half, there was no meeting in October. So we had a 2-month hiatus, basically. Nevertheless, in October, an important activity occurred, and the team itself was directed to identify members who would take on roles in areas of the service not related to palliative care. Now, whilst they've been redeployed, that occurred all the time just to fill gaps and whatever. So these were areas not related to palliative care. So Gen Med, various other areas, and 3 members elected to undertake that role. So next slide. So I met them then at the end of November. And so what that identified was this team that was incredibly in grief. So I've put a photograph there of some words. I started the meeting off, as I often do, with just something to trigger thinking and so forth. And I gave them some words. Now, these are indicative of the words that I gave them. They're not exactly the same, but they are the sorts of words. And once I opened up about kindness, about love, about laughter, the emotions were, the whole meeting really was about emotions. I can't talk about this. I'm too angry that the team has been put in this position. They don't value us. They don't think we're good enough. And you know, I can't talk about this. I'm just so depressed. And so then there would be tears and so forth. People turning off their cameras, turning off their microphones because they couldn't express themselves or didn't want to express themselves in such a way. People feeling hopeless. Well, why are we here? I just don't feel like this is ever going to end. We don't have anything more to say. Having said that, though, members also said, I can't believe that how thankful I am for X or Y or Z who said they would go into the wards, that they would do this this bit for us. Thank you so much. And then saying, I feel guilty that I didn't put my hand up. I'm guilty for not showing that amount of team spirit or whatever, and having, you know, that guilt coming through. And so we had to, I mean, I was overwhelmed really at that point. Not that I couldn't facilitate, but having to work through the level of emotions. Almost invariably, people in all sorts of disarray. So I talked to them then about bringing it all together, and I said, we can't do any actions now. What I'm seeing here is a team that is grieving for one another, grieving for assumptions, grieving for what you would want to do, grieving for the system, grieving for people who you've been trying to care for, who've died, grieving for their families, and so forth. So we talked about that, and I said, however, I don't believe that we can now wait till after Christmas, because this was at the end of November. We will have to schedule a meeting earlier than that. So I talked with the manager, and I said, we really need to have one in the next couple of weeks, and we need to work through these emotions, and we need to try and get some level of closure before the end of the year and before we start again in 2022. So next slide. And so in that meeting a couple of weeks later, we had one member of the team who joined that. She wasn't present for that first meeting at the end of November. She was one of the people who'd been deployed, and she joined the meeting. She tended to be non-engaged. She was there but not really engaged, and that was okay. She was completely depleted. Not only had she been put into a ward that she didn't really know anything, it was a COVID ward. Not only that, she'd also then been placed onto the night shift, and it was really a very difficult situation for her. I presented to start the meeting off with a series of cards with symbols on them, because I thought we needed to start to think about metaphors rather than talking about the reality of the situation, but how can we construct metaphors to explain, metaphors to rethink, metaphors for the future. And so I started with a brief overview of where we'd come from the last and you know, a summation of where I was at with all of that. I gave them these symbol cards. They were pretty randomly selected, by the way, and I wanted to start them thinking about metaphors, so they don't necessarily have to think about it's me in this situation, but how would this be different if it wasn't me? And the new member, obviously, she couldn't fully engage, but she was thankful for the team. She was thankful for their support. One of the team members who was really angry at the previous meeting thanked her and the others who went above and beyond. And he apologised for being angry. But I said apologies aren't, thank you for that, but apologies aren't really necessary. We understand at that meeting everyone's emotions were running high, and we started to talk about some of these symbols. And you know, people were talking about boots being stomped on, and you know, being in a cage, and you know, like a feather in the wind, being blown about. There was no key to there was no solutions. There's no key to the solution. You know. And so then we started to talk about, well, let's reframe all of that. You know, let's talk about what a boot might be. It's a comfortable old thing, isn't it? Looks like a comfy old boot. How about let's walking in that comfy boot, and then talking about how feathers tickle us, how cats have got 9 lives, they're resourceful and they do things. And so then we started talking about, you know, smartphones and how they've, you know, changed our worlds, and we can start thinking about all of the things that we can open the cage, and the cages are also protective. Lastly, we talked about the lighthouse, and that people couldn't understand the symbol at all. And I suggested, well, what do you think lighthouses do? And they said, well, they protect ships and so on and so forth. And I said, yes. Importantly, though, the lighthouse keeper works alone. And the lighthouse keeper works alone, and you work alone. All of these people work alone in their own way, even though they're part of a team. And those, if you didn't have a lighthouse keeper working alone, then all of these other groups would fall on the rocks. So we started to think about how we can reframe utilising these things, because it started off pretty negative, and then we started to think about cats with 9 lives, cats being resourceful, cats falling on their feet. Smartphones, how do we actually generate information from something we can hold in our hand? Walking in a comfortable pair of shoes, being comfortable in our role in the organisation. So at the end, people were able to take away their actions, that they were going to think about each one of these things in their own sort of way. And so that's how we move to the next stage. Next slide. So I guess I wanted to come back to this particular slide because I had to use these interventions. I've used them all of the time, over the time. Clearly, at times I've been prescriptive and I said, well, you need to sort of stop utilising. So, for example, people were taking their pages home. So, well, why would you do that? Stop doing that. You don't need to do that. You're not paid to be on call 24 hours a day. Let's talk about what that means. We talked about information about, have you read some of these? And I would give them some paperwork, some papers to read if they wanted to follow something up. I would challenge them and sort of say, well, why would you do that when there's other alternatives? What you can think of the alternatives, tell me what you might do instead of. And of course, that's not being aggressive in any way, it's just pushing it back. Allowing them, obviously, to work through their emotions, and the last couple of meetings very much was that. Creating them to find the catalyst for action. And that mostly the catalyst for action was in the previous meetings with regard to systems and processes and interpersonal stuff. The catalyst this last time was really about themselves. What's your catalyst to change how you feel, how you're going to move into the next stages? And of course, so I've been supportive over a number of years, but in the last couple of meetings, incredibly so, that in fact, well, the manager has had a one-on-one with me, not as a critical companion in the strictest terms, but we're able to have another conversation. And so all of these interventions have been used at one time or other in different ways. Next slide. Just to finish, 2022, who knows? I'm hoping that they will continue monthly and hopefully on a face-to-face basis, who knows. When I meet with them though, which will be in a couple of weeks' time, I'll invite them to go back to the metaphors and how they've utilised them and where they're at in terms of themselves, the systems and other people. And then we'll take things from there. Thank you, to be continued.
Thank you very much, Wendy, for that very powerful presentation, and both Andreas and Wendy talking about the importance skill of facilitation. So on that note, I'm now going to hand over to Sally, who's just going to talk to you briefly about some work that we're doing in this field to help our local region to develop facilitation capacity. Over to you, Sally.
Thank you. Emily, next slide. So some of you may already know that the work that we're doing, like Carrie says, both locally but also nationally, regionally and internationally, is thinking about how to share best practice and to have the space and time to talk about the work that we're doing that both Andreas and Wendy have so eloquently provided for us today. Although they have focused today on nursing practice, the Workforce Transformation Academy is open to anybody, any discipline, and anyone who is working within health and social care contexts. And if you put the next slide up, Emily, please. You can contact us if you've been affected by anything that you've heard or been motivated by anything that you've heard in the webinar today. Just take a look at where and how you can connect with us. We have like Carrie said, started some communities of practice that bring people together who are interested in sharing evidence, sharing experiences and learning more. And one of the themes that we're focusing on in one of the communities of practice to be launched in February is around facilitation. So learning more about some of the work and that Wendy has spoken about. We've also got an improvement COP, a culture change COP, advanced practice COP, leadership COP, etc., etc. So loads of things that you can join in and learn more and talk more about how it's affecting you and your work and skill sets. And then we have the second QR code there is the program offer. So where we work with you, your whole organizations, your teams or whatever, to think about what are some of the projects that we can do to help you understand and take forward transformation at that messy practice level. Next slide, please. So Andreas and Wendy, if you don't mind coming back on screen, there's been some lovely chat going on while you've been talking where we've been exploring some of the concepts and some of the issues. So one of the things that's come up in the questions is how did you make the decision, Andreas, to use the Parish framework when there's lots and lots of other implementation frameworks available? Was the first question.
Well, yeah, thank you. Well, actually, that was before my time, but I think the reason was quite easy. My predecessor, Doris Schiemann, she met Alison Kitson once, and well, our model of implementation, it was developed 20 years ago. And 20 years ago, the theories of implementation were not that many than they are now. And well, that was basically the reason that we used a lot of the Parish framework because we had to develop our own model, yeah, because there was no implementation model like this. But the Parish framework was quite helpful in developing it. That was more or less a pragmatic decision because that was what was available, and yeah.
And have you found that people find it hard to implement the standards once they get them and are working with their teams in workplace settings, or do people just literally pick them up and run with them and find them really useful as a tool? Do you know?
Well, there's a learning curve actually over the years. So in previous years, people thought, well, that's quite easy. We are doing this all the time. But then they realized, well, it's not that easy actually, yeah, because there is no way of collecting data on the practice. There is no exchange among nurses on how they do their work. So all these things have developed, and what we see, meanwhile, is that the facilitators in the healthcare and long-term care institutions, they are more competent to do this. There are more and more people competent in guiding these processes. Yeah, and this is really important because if we do something here in Osnabrück, that does not change practice in Germany. Yeah, so there have to be people locally in all the places, and we learn that, and we see that there is a real learning curve, and it's getting better and better, and people are now more confident also to share their experience and to say, well, I have done this and I can tell you how it works, and this is a very good development, I think. But there's still much work to do, so it's not that all hospitals and all nursing homes have people who can do this, who do a facilitator role like it's like they're supposed to. But the development is quite positive, I think.
Yeah, and I think from both of your talks, what's really come through is the level of commitment and the time that is needed to ensure that this work is embedded in what is often a very changeable workplace context. And Wendy, with your 4 years of doing this reflexive group, what do you think are some of the indicators that you really know that this is valuable work that you're doing, and how have you got a sense that, you know, are people staying because they've got 1 hour a month
you know, right from the beginning, there's been incredible commitment by the team, and you know, almost every single time. I think the smallest time was 4 people, 3 others and me, and that was because of a range of different circumstances, changes to the team, and you know, various other things. But you know, ultimately, people keep coming. And, you know, the other thing is that other groups in the organisations have heard and they've reached out and said, would you be available to come to us? And I have, over that organisation, provided clinical supervision or facilitation, however you want to describe it, depending on the groups, to managers, crisis teams, nurse practitioners, individuals, because they know that that I will commit to them if that's what they need, and they are committed to me. And in fact, after the last meeting just prior to Christmas, I had so many of them contact me individually to say thank you, and so I know that they're committed. They come, and you know, the fact that they are able to display their emotions, that they are able to feel so comfortable in the space, that they were comfortable with each other and comfortable with me to enable that, I think is testimony to their commitment to it.
Yeah, wonderful. And both of you focused on nursing, but what can you share with us in terms of how the methodologies, the approaches you're using go far beyond nursing and are applicable to many other disciplines, practice-driven disciplines? Andreas, do you want to go first, perhaps?
Yeah. Well, in the overview of the standards we did, I said there's one standard we did with the midwives, and I know in some countries it's very close, nursing and midwifery. In Germany, they're really distinct, so there are 2 different professions. And well, the good thing was it worked with the midwives. Here in Osnabrück, I have some colleagues working in physiotherapy or occupational therapy. Well, we have had some debates, but they haven't decided yet to use an expert standard for their practice, which I think is okay. But I think that the approach usually is also suitable for other professions. What other professions would have to see is if the structure of the nursing process is the appropriate one for them. So that would be that they would need to decide. But in general, the idea of putting together evidence and practice experience and then doing an implementation, I think this would be suitable for several professions.
Wendy, any thoughts?
Look, I think if you're talking person-centered practice, it doesn't really matter. It's what it is. It's the valuing of people, what they do, how they work, whatever teams and whatever contexts. So it's all about person-centeredness. Facilitation can occur across any discipline, really.
There's one last question there, Sally, that's quite important to address from Cecilia. Would you like to, can you read that? She's just asking, how are you streamlining all the people that needed help if you cover all staff and only a few are facilitators?
That was for me or for Wendy?
I think for Wendy in particular, we've put some comments in the chat box, but Wendy, I don't know in particular for you, because that was a big project, wasn't it, over a long period of time. How are you helping to build capacity, I guess, is when there's only a few facilitators?
So what we are hoping to do at Federation is to re-engage with a whole of state approach to practice development, a whole of state approach to person-centered practice, to facilitation and training people in that work right across the board. I have a number of contacts with the senior nursing groups, but not only that, obviously the senior medical groups and allied health groups as well, because we have all of those disciplines in our university, to actually say, look, these are principles that apply generally, and we can train people. We can bring you through the conceptual basis of it all, but we can also work alongside you. We can actually help you to actually embed these things as day-to-day activities, not something that happens, you know, randomly or sporadically, but it's part of the work in which you do. I actually think after COVID, if there is ever a thing called after COVID, that this is going to be more important than ever.
Absolutely, thanks Wendy. And there's some very helpful examples of resources that are currently available to support facilitators. And of course there is an international critical companions network hosted by the University of Wollongong, which has membership from colleagues who work in the International Practice Development Collaborative. Thank you so much to our guest speakers. We're almost out of time. So to Professor Andreas Büscher and Professor Wendy Cross and Professor Sally Hardy, thank you so much. We've got lots of lovely comments and feedback in the chat box saying that it's been very helpful, very thought-provoking, and people have felt very engaged and really enjoyed it. It's provoked some interesting sharing of resources in the chat box as well.